Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video. And this is a patient who attended with bilateral dead skin plugs. Now, I actually forgot to video the first minute or so, but you didn't miss much. And this skin plug is quite medial, and what I mean by that is quite deep in the ear. So in the latter half, up against the eardrum also. And because it's a dead skin plug, some of the skin is still somewhat attached to the canal wall, and you can see this outer white peripheral layer here. So this dead skin is on the periphery, and eventually this skin, if this plug has not been removed, will be forced into the center by more freshly secreted dead skin. And as it reaches the center, it will oxidize and become dark, just like the rest of the plug. So what I'm trying to do here is detach this peripheral layer of skin off the floor of the ear canal. You can see they've got really dry ear canal. So this patient is elderly, and as we get older, we're more likely to suffer from dry ears, and that's because our sebaceous glands and ceruminous glands, which secrete sebum and an oily protein-rich sweat, respectively, the glands become smaller, and so they secrete less sebum and the oily sweat. And the sebum and the oily sweat is designed to moisturize the ear canal. So it sits on the skin, and because it's hydrophobic, it locks in internal moisture within the skin, so that internal moisture can't leak out and evaporate. And the sebum and the oily sweat also act as an acid mantle, so we want the pH level of the ear to be mildly acidic, and the mild acidity helps to inhibit the growth and colonization of more harmful pathogenic bacteria. So as we get older, these glands, they become smaller, and they secrete less content. So this is one of the reasons why this patient's got really dry skin. And it's quite a tussle here. I am going to use the forceps in a moment, but this patient has got quite a narrow ear canal, and the forceps were taking up all the space. Now, I think some new forceps need to be designed. I know a lot of viewers also feel that by watching the videos. So there are some cup-shaped forceps. They're called Henkel forceps, but they're quite large. And so you don't have any serrated jaws on those. They are almost like a hippopotamus mouth, if you like. And they can be quite effective. I have used them a few times on some really tough cases, but you need, although there are some micro ones, but I think they still take up the space of the ear quite a lot, so it's hard to visualize what you're grasping onto. But if someone's got a big ear canal, wide ear canal, they're pretty useful. They are pretty good, actually. So eventually I will go back to the drawing board about some forceps design, but at the moment I'm just really busy with everything else. So I think, am I using the forceps at this moment? Let's have a look. So you can, and these are the micro forceps. So these are the smallest forceps that are really available for ear care. And you can see it takes up a lot of space. And the forceps themselves, it wasn't pulling this plug. It was just tearing apart the dead skin. It's almost shredding it. So I'm just going back in again. Gotta be careful because we're working quite deep. I don't want the jaws to make contact with the side canal walls, because of course that would be uncomfortable. And one of the reasons why I'm quite cautious around the bony part of the ear canal, which we all should be, but I've had trauma to my ear canal many years ago, so I know exactly how it feels. So I'm always trying to avoid touching that where possible. Now, some patients may be more tolerable to the contact than others, but it's hard for me to know as a specialist who is going to be sensitive to me touching their bony part of the ear canal, who's not. Occasionally, in really extreme cases, more so in cases of keratosis obturans, which this is not keratosis obturans, but this may well develop into keratosis obturans if this plug is not removed, because this plug is just going to get bigger and bigger, because it's just layers of dead skin, and it will start compressing against the canal walls. It will initiate the bony resorption process, where living on the surface of the bone are specialized cells called osteoclasts, and when the skin plug is really compacted against the canal wall. They can initiate these osteoclasts, which kind of break down the bone into its minerals and redistribute those minerals to other parts of the body via the bloodstream, so new bone can be formed. And that's done so by osteoblasts. They are the specialized cells that generate new bone, and you can get a widening of the ear canal. And so if this plug has not been removed, it may well eventually compress against the canal walls. And one of the hallmark symptoms of keratosis obtrans is ear pain. Now, this patient didn't present with any otalgia, so ear pain, so you can't really label it as keratosis obtrans for that reason, but it's probably a pre-keratosis obtrans case. So just trying to tease this through, and this is where the narrow section of the ear canal is. You can see it's getting trapped. I think I'm going to use the right ear hook, and this is the angled one in a moment, and the angled one works really, really well. It just gives me more maneuverability, more accessibility. Even if you're not using an endoscope and you're using an ENT operating microscope or head-worn loops, or so we use it with the wax scope, because of the bend it has, your hand is not obstructing your line of sight. So more so with an ENT microscope and head loops, your hand kind of almost goes in front of your eye line with the normal straight ear hook, depending upon which part of the ear you're trying to remove the wax from. And your line of sight can be obstructed by your holding hand. But when you've got an angled instrument, because it's kind of you're holding it away from your line of sight, you just have better visibility. But also with an endoscope in particular, you have much better insertion and maneuverability. So just trying to get suction grip on the core of this plug, bring it forwards, but again it just got trapped. You can see where I've applied some pressure in the middle there. There's an indentation. So I think at this moment I'm gonna get the hook. I'm gonna, because it's tapered, we're gonna glide it in and behind, much easier. And I think this comes away in two parts. So this is the first part. I managed to take a still image of all the dead skin that I removed. So you'll see that at the end of the video. So in terms of this patient, I've recommended they use on a weekly basis some medical grade olive oil spray just to help moisturize the skin. So if their ear is not producing the natural sebum and oily lipid protein rich sweat, you can use some medical grade olive oil as a substitute to help moisturize the skin. They don't get water in their ears, so that's good, and they don't poke in their ears. Now they do wear hearing aids. The slight issue with hearing aids, and obviously we want people to wear them if they need them, is that it can alter with the natural migration of skin. So all this skin, it originally was secreted on the center of the eardrum, the umbo. That's the progenitor site. That's where all the epithelial skin cells are born and made, right in the middle of the eardrum there. And this skin, as it's secreted, it then moves sideways and lines towards the entrance of the ear canal. It lines the inner 2/3 of the ear canal. And so that skin naturally is a constant conveyor belt. It's being replaced by new skin, and as the skin migrates sideways towards the entrance, when it reaches the entrance, it starts to shed and naturally come out the ear. When you've got a hearing aid, you're hindering that natural epithelial migration of skin. So this is their right side. And you can, again, it's not really wax, it's all dead skin. It's just partially blocked the tube. I've just put some oil in, so you're going to see moments where it's slightly blurry. So you've got to be careful when you put oil in and you're suctioning with an endoscope, because the oil will be in front of the lens. You can get moments where it might be a bit blurry, so you just got to be cautious. So again, I'm just trying to remove that white peripheral matrix of skin, which is a hallmark of keratosis obtrans actually, but again I would say this is pre-keratosis obtrans because there's no pain and there's also no remodeling of the ear canal, so no widening, which is another hallmark of keratosis obtrans. It's quite a mushy consistency, so with dead skin it can work in two ways. You can get really mushy sticky skin, or you can get really crystallized, dry, crusted skin. Because this patient wears a hearing aid, I suspect that they've got increased humidity in the ear canal, which has caused this skin to become quite mushy. So it's just trapped deep in the ear, in the inferior recess. So I was just pulling it inwards from the canal walls. You can see this section is quite dark. So again, I'm just trying to lift away. Typically, it's either trapped in the anterior recess or inferior recess. So as I'm pulling it away, I'm kind of coming away, but towards the left-hand side of the ear canal. It's just blocked. This is the patient's right ear, so on the left side it'll be the other way. Just put some more olive oil. I could feel this trying to come away, and I wanted to coagulate this mushy dead skin so I get a better suction grip. Again, just peeling it off the canal walls. And that's that blurriness I was referring to. So again, I think I've got a decent suction grip now. So as I'm pulling this, I'm kind of going towards the left-hand side of the ear canal to get it out the anterior recess. And I'm going slightly up as well to retrieve it from the inferior recess. So the anterior recess is a pocket near the eardrum on the right-hand side of the ear canal. On the left, it'll be on the left-hand side. And then the inferior recess is when you have a widening, a basin almost, near the floor of the eardrum. And so quite often you can get wax or dead skin trapped in those regions. So I'm just going to wriggle this out, so it's quite a sizable plug. Just going to re-enter. I'm happy with that. You can see the patient's eardrum. And you're going to see all the dead skin that I removed. So you can just see how dark it is. It's almost pitch black. Well, I hope you enjoyed that video, guys. Do take care, keep well, and speak soon. Bye.